fellow is from University Hospital Cleveland Medical Center, Tashinga Musonza, and the faculty is Leigh from WashU St. Louis. Just a reminder, we'll have 2 cases to go through with good fellow feedback, and at the end, there'll be some time at the end for people to discuss. Tashinga, you want to go ahead?
Yes, thank you very much. So we'll get started here. So here's the outline for the afternoon. So we'll start off with a brief introduction, basically just talk about the epidemiology, anatomical staging, and the limitations for anatomical staging, then rationale for systemic therapy. And after that, we'll dive into case 1, then we'll do a brief evidence review, then we'll follow that up with case number 2, then we'll do another evidence review, then my conclusion, so to speak. So, pancreatic cancer, as we know, is the third leading cause of death, cancer mortality in the Western world, and the incidence is increasing. And by 2021, 68,000 cases were identified approximately, and 48,000 deaths were due to pancreatic cancer. This disease has been devastating in the state that, most of these patients, when they present, they've advanced disease, 50% metastatic, 30% local advanced, and 20% being anatomically resectable. And as we know that surgery offers a potential for cure as part of multimodal therapy. And due to the, high rates of distant failure, even in the localized disease where, overall survival is less than 10% with surgery alone, it's axiomatic that, pancreatic cancer is a systemic disease. We've shown that, or studies have shown us that, combination chemotherapy is superior to traditional gemcitabine monotherapy. And with regards to resectability, multiple societies have tried to define resectability, anatomical resectability. So today, the focus will be on locally advanced pancreatic cancer. And this is the NCCN guidelines, anatomical resectability. So with regards to the head and ansnet process, there's solid tumor contact greater than 180 with the SMA or celiac axis, celiac artery. With the pancreatic body and tail, there is also greater than 180 degrees contact or with the SMA and celiac axis. And in addition to that, we have solid tumor contact to the celiac artery and the aorta. And with regards to venous anatomy, in local advanced pancreatic cancer, we do not have reconstructable or target sites for reconstruction. So there are limitations to anatomical staging, as we all know, that number one, it doesn't account for tumor removability, which is just, we can remove this tumor from the patient. Then it doesn't account for resectability, which is consideration for biologic and conditional factors, and biologic factors being those features that may say to us this patient is systemic disease that is advanced. Conditional factors, these are the patient factors that may preclude getting the intended multimodal therapy. So what we try to focus on nowadays is the clinical resectability, is that the patient will receive oncologic benefit from this operation. And that's the ABCs of pancreatic cancer, the anatomy, the biology, and the conditional factors. And we know that the conditional and borderline factors were introduced by the MD Anderson group back in 2008, later updated in 2012, with borderline biology being CA99 greater than 1,000, subtle imaging features consistent with the presence of maybe metastatic disease. The Heidelberg group in Germany later showed through a retrospective series that the CA99 is indicative of survival. The higher the pre-op CA99, the lower the chances of survival, or the poorer the prognosis. Then the borderline conditional factors, again, this is based on the functional status, equal, greater than or equal to 2, and these patients are octogenarians. They have multiple comorbidities requiring intervention or to be taken care of. And the Istanbul group again showed that performance status of 2 to 4 is associated with poor survival for all stages of pancreatic cancer. And building upon from that, the MD Anderson group had shown us that a third of the patients who had conditional borderline the fact is they progressed to metastatic disease whilst getting neoadjuvant chemotherapy. So really the rationale for preoperative systemic therapy, some may say it's philosophical, but because of the high distant failure rates in resectable disease, we think this is a systemic disease. And the cluster study showed us that more than 95% of these patients with resectable disease, they have circulating tumor cell DNA, therefore making this a systemic disease. And we know that 20 to 50% of patients do not receive planned adjuvant therapy, and because of post-operative complications, and some of them because of poor performance status. And when you talk about the return to intended oncologic therapy, again, this was shown by the MD Anderson group that 58% of the patients after upfront surgery were only able to get the intended multimodal therapy, as compared to 83% when therapy was administered in a neoadjuvant fashion. We also think that the giving neoadjuvant therapy really selects for favorable biology and favorable performance status, in the sense that the patients that would have otherwise progressed after upfront surgery, if they do progress during neoadjuvant therapy, then they're spared from a non-therapeutic laparotomy. In advanced disease or local advanced or borderline resectable, we also think that we can downstage, I mean, I use the term downstage loosely, we can downstage the disease and be able to do a resection, a curative intent resection. We can also monitor for indeterminate lesions during this time, the patient's getting neoadjuvant therapy, and we can treat micrometastatic disease. So that being said, we'll move into case number one. The patient we have today is a 56-year-old female who developed Dow epigastric pain back in March of 2021. She had anorexia, some cyclic right upper quadrant pain. The patient herself, she felt a palpable mass and presented. A CT scan was done. This was just a regular CT scan, which showed a 5-centimeter pancreatic head mass. She is on Coumadin for mechanical aortic valve, which she had placed for bicuspid aortic valve. She has a pacemaker for sick sinus syndrome. Her exam is unremarkable except for the fact that she does have a palpable epigastric mass.
So I think you can keep going with the labs.
Okay.
Mm-hmm.
Okay, so the labs are done, and the CA99 is normal. She's a non-secretor, and here's the imaging. And what I would like you guys to ask or us to focus on today is the venous anatomy here.
Yeah. So why don't you show the CT scan slowly, and then I'll call on a couple of fellows to see what they think and what they would do next.
Okay.
Okay. And presuming you got a biopsy, right?
Yeah, the biopsy is pancreatic ductal adenocarcinoma.
Okay.
Sorry, quick request. Can you scroll through the whole scan? I think it's important to remember that to look at the whole scan, even though I know we're mainly looking at the pancreas, but we stopped just below the pancreas.
Okay. So how about Jared Forrester from Providence, Portland? What do you kind of think of this scan, and what would you like to do next? Any further sort of workup, and what are your thoughts?
Yeah, so looking at the scan, it looks like just after the splenic vein enters the portal vein, it looks like the tumor causes encasement and also occlusion of the superior mesenteric vein. And then looking at, and as it goes down, it doesn't look like it's going to an area where it is a reconstructible, at least on this axial cut. So I'd be concerned, and I would stage this as locally advanced pancreatic adenocarcinoma. So for this patient, I would fully stage them, including getting a CT chest, and then would talk at tumor board about getting this patient started on neoadjuvant chemotherapy, as well as discussing chemoradiation therapy pending her completion of chemotherapy.
Okay, and how about Matthew Iyer from Duke? What's your interpretation and plan?
Yeah, thanks. I don't know if I could have said anything much better than Dr. Forrester. He provided an excellent response, and I agree that the patient would benefit from neoadjuvant chemotherapy. There are specifics about the scan that I could comment on. I see the portal, I see the SMV going out, and I see at least some, if not more than 180 degrees of abutment of the SMA tube.
Okay, perfect. Would anybody, would either of you two plan to do a diagnostic laparoscopy before starting neoadjuvant, or would you start the patient on neoadjuvant?
I think that's a great consideration. I know Dr. Rocco over at OHSU does that pretty frequently. I think for this patient, especially given the nature, I know Dr. Visser put in there, neoadjuvant implies actual surgery. I'd be concerned that taking this patient, if this patient would even get to surgery. So I think a diagnostic laparoscopy at the time of a port placement would make sense in terms of staging.
Yeah, I think it's pretty institution dependent on, and I'm sure that some of the other fellows and faculty can comment as well, but it's pretty institution dependent. But I think that they both sound like a very reasonable plan. Would you do, there's some questions in the chat, would you plan for any washings if the diagnostic lab was negative?
Yeah, if you're in there at the same time doing an ultrasound, not seeing any liver lesions, not seeing any obvious peritoneal involvement, then washings would be reasonable.
Okay. All right. I think we can, so Tashinga, do you want to take over and review kind of the pertinent?
Yeah, I completely.
In here. Can I make a quick comment?
Yes.
Yes.
So at this time, just to be clear, at this time, this is an unresectable tumor. Am I right? I mean, this is not, so I don't think we should use the word neoadjuvant. I thought Flavio was going to say this, that this is unresectable unless you get a good response. There's no reconstructible distal target for inferior target for SMV, right? And this thing is against the SMA. So I mean, I think we can call it induction chemotherapy, but when we say neoadjuvant, it implies that this is in a category that we have some reasonable confidence we're getting to surgery. And I guess I would argue that this, strictly speaking, at this time, to me, this is not. This is something that's unreconstructible, unlikely unless we have a dramatic response to become resectable, but definitely possible. But most of these don't become resectable. So, Flavio, am I right that this should call it induction chemotherapy because we don't know that this is ever coming to surgery?
Yeah, I would say that was my one comment in the chat is I couldn't tell for sure if the cava or the left renal vein was even involved in this or not. I guess so. My first question is: are we sure this is a pancreas protocol CT to get fine cuts, arterial and venous phase? That would be my number one thing. I agree that it's hard to call something neoadjuvant, although we do it with locally advanced disease. I think a little bit more now because we're taking more of these patients to the operating room, right? And so I think the locally advanced moniker, I mean, I think, you could, if you really wanted to be a stickler, you could actually break it down into the locally advanced categories, where, as Brendan said, there is a, unlikely to be ever downstageable category, in which case, then, yeah, I think induction would be a better term. I don't know if I made it more complicated, hopefully I made it less.
Yeah, and in part, I just don't want people, the fellows on this, to look at this and think, because we're talking about neoadjuvant as if and thinking to themselves, shoot, are these other centers taking on this kind of a tumor? Because this is terrible, you know, with complete occlusion of the SMV and no obvious distal target for reconstruction. So this is terrible. And this is a prayer that you could get this back to downstage to something that you can take out for the most part. Most of these are not coming to surgery. So we just want to spell that out more explicitly, I guess, in my mind.
And may I ask, I don't have a lot of experience with the diagnostic lapse prior to induction therapy. What is the thought of how that's going to change the patient's practice other than you know, permanently ruling out exploring should they have a good response?
I'd love to answer that question. This is Iannetti,
Go for it, Dave.
unless that's to the fellows. So I appreciate the comments regarding induction chemotherapy versus neoadjuvant. You know, we're eternal optimists to be hepatobiliary surgeons, so that's just the way we are. But we feel strongly in this organization that people who have upper GI malignancies, gastric, duodenal, pancreas, biliary, who are going to have either whatever you want to call it, neoadjuvant chemotherapy or induction chemotherapy, to rule out occult peritoneal metastatic disease. And despite the best CT scans, MRIs, PET scan, this scan, that incidence isn't low. It's, you know, 15%, maybe 20% in some patients. And one, we all want to accurately stage the patients. But secondly, just from a very practical point of view, it really changes the flavor of how you manage the patients for the medical oncologist as well. Because if the intent is curative intent, and we all understand the reality of that particular comment, then, you know, you'll hit them hard with FOLFIRINOX or whatever, and the patients may have some side effects, and you're kind of saying, all right, you kind of need to tough it out a little bit because we're trying to get to the next step, which may be surgical intervention with curative intent. However, if you have peritoneal metastatic disease, then your goals of treatment are completely different. Now you're just trying to control their disease as best you can with the best quality of life that you can. So then the medical oncologists are much more likely to back off of dropping, you know, say the platinum aspect, or their lower dose reduce a lot sooner than they normally would if they weren't going for curative intent. So we feel strongly for a lot of reasons that staging laparoscopy prior to neoadjuvant or induction chemotherapy is really important for the patients and the whole care team.
All right, we
Super
should
helpful,
shift the
thanks.
focus back to the fellows that we've let them talk.
Okay, let's keep going.
Okay. So as everybody astutely noted, that there's venous involvement without a target there. So I already mentioned that. So we ended up doing a staging laparoscopy for this patient. We did a port placement. We enrolled her in a study with modified FOLFIRINOX and then followed by radiation. Again, this is after 4 cycles. I won't go through this. There was no progression. I'll go on to, you know, she ended up completing 12 cycles of modified FOLFIRINOX. Her ECOG is 0. She's doing CrossFit for, you know, 2 days a week when she was on chemo, 4 days a week when she was off chemo. The CA99 is still normal, no radiographic progression on CT or chest or have CT pancreas protocol, which you will see here. So I'll show you right again, focusing on the venous anatomy, and I'll go slowly with this and then just show a still image. So again,
Okay, so how about Winifred Lowe from UPMC? So the patients had, it sounds like, a lot of neoadjuvant chemo, done pretty well, despite all the medical problems, is pretty fit, and has this interval scan. And is this before or after radiation?
this is after.
After radiation, got you. Okay. So Winifred, what are your thoughts? What would you do next with this patient, and what discussion would you have with that patient?
Sure. So when I look at the scan, I don't see that there's meaningful improvement in the degree of tumor involvement for this SMV, that there's still not a good distal target to truly offer a reconstruction option, and that there's still a significant degree of SMA involvement. I think at this point in our institution, we would recommend consideration of a clinical trial, given that we've exhausted upfront chemotherapy and chemoradiation.
Hey, this is Leigh O'Kewen from Case. So what about that? How many trunks, what veins make up the SMV? What two trunks?
I'm sorry. I think I cut out.
What two venous trunks form the SMV?
Sure. So you'd have your jejunal veins and your iliac veins feed into, ileal veins feed into your SMV.
Right. So what about that right there? Go back a couple of slides, Tashinga.
Yep.
A couple of frames.
Not today.
So what about that?
Okay. So I guess
right. So the ileal branch is out, but that's a big jejunal branch that is plumped up over time.
Mhm.
So
I guess in my hands currently, I would not feel like I could use that reliably for a target if the ileal veins are still out. I'd still be worried about venous drainage there.
but you only need to preserve one mesenteric, either the jejunal or the ileal. You can preserve one, you can preserve mesenteric venous outflow. Just something to keep in mind.
Okay, thank you.
Yeah, I agree with that, with those comments as well. I think to me it looks like there's possibly a reconstructable target here. How about Ricardo Bello from MCW? Would you consider resecting this patient at your institution? And what are your institution's feeling on radiation in this setting?
We would definitely radiate in this setting, and other less extreme settings too of resectability.
So what would your criteria be for preoperative radiation in someone with pancreatic cancer?
Radiate everyone. Big believers in it.
Even resectable?
Yes.
Okay. And okay. And you would offer this patient surgery as well?
I mean, I know theoretically just preserving the ileal would be enough. I think this would be a very thorough multidisciplinary discussion in tumor board. And I would love to know what Dr. Evans, who's in this talk on this call, would think about whether this is even feasible. This seems like a pretty extreme example of a locally advanced. So yeah, we do vascular reconstructions pretty often in our institution.
What if this patient was an 83-year-old with kidney disease and COPD? Would you consider that then?
A lot less likely. Obviously, depends on the degree of their COPD and how functional they are.
Okay. What would you, if you were not going to offer them surgery, what would be your alternative management plan?
We have a randomized controlled trial using chemosensitization with not only gemcitabine, but also mitochondrial drug dose escalation with radiotherapy. And when these patients are not operable, then we tend to refer them to be involved in this study.
Okay. Tashinga, do you want to tell us the rationale for radiation in this patient, and then tell us kind of what you guys did?
Yeah. So, I mean, the rationale would be that, for this patient with local advanced pancreatic cancer, really your margin, you want to have local regional control. Your margin is likely to be positive when you have local advanced pancreatic cancer. So that will be the rationale for doing radiation. In this particular case, I mean, I just briefly here, we're talking about the jejunal branch, IMV, the ileal is out here. Maybe there's some involvement of the mesenteric, transverse colon mesenteric area here. So we ended up, I mean, we took this patient, of course, to the operating room. I was going to ask these questions, but we can proceed and talk about what we did. So in the operating room, of course, we took down the gastrocolic, the ileal branch is out, the jejunal is reconstructable. The IMV here is going to be out, so we resected this portion of the SNV. We have a target here, the splenic vein, so we ended up swinging the jejunal branch to the splenic vein. After doing a diagnostic laparoscopy, of course, there was some tumor ingrowth to the transverse mesocolon, but it looked like this could have been just like, treated already. So like I mentioned, we did a first jejunal branch was the main outflow. We started off with an artery first procedure. And as I've mentioned, we swung that SNV to the splenic vein, ended up doing a right colectomy. And this was back in March of 2021, and the patient is still alive right now with almost non-detectable CA19-9.
Okay, perfect. You can move on.
All right. So just the rationale for pure systemic therapy. We already mentioned that PDAC is a systemic disease. We want to assure the receipt of chemotherapy. And as we've seen from this case, is that sometimes the anatomy does not predict the biology of the disease. Systemic therapy offers us, or neoadjuvant therapy offers us, a pressure test for biology and performance status. We also want to improve local regional control and distant control. Again, these are foundational studies. We knew that FOLFIRINOX was better than gemcitabine in overall survival for metastatic disease. And building upon that, historically, the PRODIGE 24 study looked at resected pancreatic cancer. But this was a highly select group of patients. They recovered from from their surgery. They had not shown progression. They had CA19-9 less than 180, and they were randomized to 24 weeks of FOLFIRINOX or gemcitabine, with the primary endpoint being disease-free survival and secondary being overall survival and toxicity. And from this study, it was shown that the FOLFIRINOX disease-free survival was better with FOLFIRINOX as compared to gemcitabine. Overall survival was also better as compared to monotherapy. Building upon that, then we asked the question: is all adjuvant therapy, combination adjuvant therapy, the same? So we looked at resectable treatment naive PDAC in SWOG. Patients were randomized to 12 and 12 weeks before and after surgery, modified FOLFIRINOX to gemabrax, and this was a pick the winner kind of study. 2-year overall survival was the what we're looking at. And again, from this study, we identified that they're probably similar. But one of the telling stories from that is that most patients in both arms received their neoadjuvant therapy 80% as compared to the historical 25 to 50% when therapy was attempted in the adjuvant setting, showing that this gave us a chance to administer the effective therapy before the patient got frail or before the patient had complications. And most of these patients were able to proceed to surgery. The 2-year overall survival, as I've mentioned, was about the same. The local regional control is about the same. And then we asked the question about chemoradiation or chemoradiotherapy in the PREOPANC trial. Though this study has some major flaws or considered to have major flaws, it gave us some good insights with regards to resectable and borderline resectable pancreatic cancer. So patients had upfront surgery, randomized to upfront surgery versus gem followed by chemoradiation. And overall survival was the outcome under study. And from this, we saw that overall survival was similar, but the 5-year overall survival was better with neoadjuvant therapy. However, what was more compelling was the local regional control with the disease-free survival. The resection rates for R0 as well as the node negative were favored with neoadjuvant therapy. Another important take-home point was that 39% of the patients in the neoadjuvant group did not undergo surgery. Most of them progressed. So these patients would not have benefited. I think in my mind, they would not have benefited from surgery. So that's the the pressure test that we talked about. And the mortality and morbidity was similar in both groups in the pre-op PANC trial. And one more compelling observation from this was that in the surgery first group, the overall survival was much worse with a positive margin, but this discrepancy was attenuated when patients received neoadjuvant therapy. Again, just a briefly definition of margins that this is controversial. When we go from a no tumor on ink versus 1 millimeter margin, greater than 1 millimeter margin, our R1 rates increase from 50 to 80%. And this has been shown by the Heidelberg group in Germany that, with upfront resection, a margin of greater than 1 millimeter is associated with an overall survival of about 42%, 42 months, as compared to an R1 of less than 1 millimeter, where the median survival is 23 months. So margin clearance is really important. We talked about biologic staging as defined by the MD Anderson group, and we mentioned that anatomy does not, predict biology. This is the survival curves from the Conco 001 trial, where you look at the observation group versus the GEM group in the post-op period. The median survival was almost the same. Then there was some long-term survival regardless of the stage, and this was by the TNM staging. So again, biology does not really predict survival. And then building upon the concept of biology, the Heidelberg group in Germany showed that the pre-op CA99 is really associated with your survival. So the higher the CA99 for all stages, the lower the survival. But again, this observation or this discrepancy seemed to was attenuated with neoadjuvant therapy. So again, the rationale for neoadjuvant therapy is, one is to give the most effective therapy when the patient can tolerate it or handle it, treat micrometastatic disease, and to improve local regional control. So then the question is, how best do we assess our patients? It goes back to the ABCs of pancreatic cancer. This is our approach here at the University Hospital. So again, this is all happening at the same time. We start off with conditional resectability. Is this patient, can they undergo an operation? Can they undergo the required multimodal therapy? And then we go back to biology, and finally we go to anatomy. Again, my attending Dr. Okuno will tell you that, we learned about pancreatic cancer in kindergarten. The ABC is conditional, borderline, and anatomy, and that's how we typically approach these patients. So building on to case 2, this is a 32-year-old young man, abdominal pain over a year. He felt that something was wrong. He had a CT, which was done. It did not show any malignancy. Then this was back in March. Came back in August with obstructive jaundice, had an MRCP. Eventually, they showed a mass in the head of the pancreas at an EGD EUS. Again, negative malignancy upon the EUS. CA99 was within normal limits. And here's his imaging. And we're paying particular attention to the arterial involvement.
Just go slowly.
Mm-hmm. I apologize. I'm using this Mac, using this pad. I'm having a hard time slowing down, but I'll do that right now. Let's go like that.
So how about save Ahmed from USC. What's your interpretation of this, and what would you plan for the patient?
I'm sorry, can we have you go just scroll through it one more time? I'm just looking through that.
Yeah.
Yes, I mean, I see at least, involvement of, it's hard to see without the cross-sectional view, but it looks like the SMV portal vein confluence is still open, but there is, gross encroachment of the mass, at least 180 degrees.
How about the SMA?
And that's what I'm trying to see now.
Let me go back.
I know it's hard when it's on a small screen.
Yeah, and yeah, definitely contact with the SMA as well.
Okay, so what would your plan be?
So it also a plan for a neoadjuvant approach given, at least borderline resectable in this case, provided we have whatever the images showed on the endoscopic ultrasound as well on the biopsy, but I'd plan for a neoadjuvant approach.
Okay, and how about Jenny Leighting from Mayo? What would you advise this patient, and when would you plan to re-image them if you're going to give neoadjuvant?
Yeah, so we would certainly do neoadjuvant. We would also, we are also proponents of diagnostic laparoscopies. So in this patient who has locally advanced disease, venous as well as SMA involvement, that would be someone where we would do diagnostic laparoscopy, start on neoadjuvant chemotherapy, and follow up in 2 months with repeat imaging.
Sounds very reasonable. Okay. Why don't you tell us sort of what you did or what you found, and sort of what you had discussed with the patient?
And I agree with the findings that you guys identified. So you did that EUS, FNA, and of course it showed that the patient had a PDAC. So we ended up recommending neoadjuvant therapy after a diagnostic laparoscopy. We did a CT chest. I think in this particular patient, a PET CT was also done even as well. We also ended up recommending radiation therapy. And as I've mentioned, we did a PET scan for this particular patient. So
Can you tell us why you did a PET scan?
So, I mean, I don't think it's the standard, but we just wanted to make sure that this patient did not have any kind of metastatic disease, given the fact that he had had a long interval prior to presenting to us. He had pain for about a year.
And did you do a PET scan pre chemotherapy or just post?
This was post.
Right.
Okay.
Show us the imaging.
All right.
So how about David from Toronto, David Hennell. Sorry if I'm butchering people's last names. My apologies.
No problem. Can you hear me?
Yes.
Thank you, Tashinga. The cases are great. The presentation is great. Again, this is like a Zoom video, so it's unclear to me. The SMA still appears to be at least 180 degrees abutted. I thought it looked more encased on the previous imaging. I'm unclear whether the hepatic artery is involved, and there seems to be involvement of a replaced right, if I see that correctly. So the way I see it for now is encasement of a replaced right and abutment of SMA.
So what would your plan be?
Patient's young, fit, responded well. I believe that we have all the up-to-date restaging. I think he would be a surgical candidate, albeit it's a high-risk surgery with an SMA reconstruction and a replaced right hepatic artery reconstruction.
And Tashinga, did the patient complete all their neoadjuvant, or was this
Yes,
sort of halfway through?
Yes, the patient did, and he did well. I mean, he was still exercising, and this is a very young guy. He's 30, 32.
Got you. Okay. Why don't you tell us what you did?
So we're about to plan to go to the operating room for this patient. Again, this was my case that was supposed to do about a week ago. So ended up coming in with, cholangitis from an occluded stent. We had Klebsiella bacteremia, and this was treated, had a stent replaced, and we're still planning on operating on this patient. He understands that this is a high risk operation. We'll do a diagnostic laparoscopy first. We'll take as many specimens as we see as we proceed with the dissection. We're going in prepared for probably vascular reconstruction, be it the vein, and like what David talked about, the replaced right. I mean, sometimes you can take that without any issues. I guess the question would be, when is it safe to operate, if anybody would like to comment on that.
And what is your plan with the SMA?
The SMA, we can, the plan is to really, we think that, I mean, from looking at the imaging, at least in our experience, and most of the times when we go in, when we take biopsies, this is usually a treated tumor, or there is no tumor at all. But we'll go in planning to do a resection and reconstruction if we have to do that, given this patient is very young and it's proven to us that he has been able to tolerate all of the chemotherapy without any issues at all.
Okay. Do you have some other teaching slides for this?
No,
I had a quick question. Hopefully you guys can hear me. So I'm just from my learning too, how do you approach this when there's that arterial involvement? Do you do a SMA first approach in order to get that biopsy to ensure, or do you commit understanding that you may have a positive margin at your SMA?
We'll do an artery first approach before committing.
Do any of the other faculty want to comment on what they would do with the SMA on this patient?
So I just wanted to ask Dr. Musonza about, you say artery first. So which approach? There's actually multiple artery first approaches, right? Because there's an anterior, there's a posterior, inferior. Which one would you attempt in this one?
I'll go posterior first. And then if that is all clear, then I'll go anterior. I mean, you can do I think you can do a combination of all the approaches. I mean, go from behind, make sure that you're clear posteriorly. And if I'm happy with that, I mean, I don't have much experience with this. If I'm happy with that, then I'll go anteriorly.
Yeah, I think it's good to know that there's kind of different ways to skin the cat, if you will. So you should be kind of comfortable and familiar with different ways to approach it. I personally like that approach, and I like if you're confident that you can get it out, you can split the pancreas and get that anterior approach, because that'll get you right on top of the artery. In Japan, they do a lot of inferior approaches, which, as you can imagine, with their population, works really well for them. I just wanted to kind of then address that question of the right hepatic artery, because there's a question about reconstructing it. And I got to be honest, Kim Burton's, who's now in Ottawa, is one of our fellows, wrote a nice experience with us that you really rarely have to reconstruct it. The challenge is always making sure that your bile duct is perfused. So if you're going to just ligate it, to make sure that you're going up on the bile duct. But I don't know if others, have a different experience. I just find that you're reconstructing a small artery. You have a potential for a leak. So you end up having more problems than it's worth. So just curious to see what your approach would be for the right hepatic. If you're going to reconstruct it, ligate it.
We'll ligate it. In our experience, we've ligated the right hepatic artery without having any issues in some of these cases, and it's often fairly small that even reconstruction is challenging. And even if you're able to reconstruct it, at times I think it thromboses.
I would say at our institution, we would probably favor we do short course high dose MRI guided radiation a week-ish before surgery, like 80 gray, and then we would try and just chip it off the artery and preserve it.
Okay.
Hey, it's Eddie. Can I throw an alternative approach?
Yes.
I'll acknowledge, this is, we sort of take a fairly aggressive approach with locally advanced pancreatic cancers, and we give them laparoscopum and then neoadjuvant chemotherapy for about 6 doses or 3 months. We're a little bit more on the aggressive side with irreversible electroporation, using it as a resection tool. So we've redefined sort of the way IRE is used. We're not talking about in situ IRE. We're talking about, and not even talking about margin accentuation. This is IRE assisted resections. The outputs of the generator are very different, and we would treat along the artery as well as the vein, maybe take the vein. And we're looking forward to publishing our 126-ish cases in the last few years on that. So we think that's a promising yet currently experimental technology. So keep your eye out for that one for the future.
Okay, Tashinga, why don't you wrap this up?
Okay, so just a few more teaching slides here, just things to think about. Total neoadjuvant therapy approach, and this is combining your neoadjuvant chemotherapy with chemoradiation, which addresses 2 key concepts, concerns in borderline resectable and local advanced pancreatic cancer. So we're talking about the positive margin risk and the micrometastasis, which are a concern. So this paper was just looking at, this is retrospective, looking at the NCDB data on patients that got TNT versus chemotherapy versus chemoradiation, to look at which of these patients had the most pathological complete response. So the NAT variables in this paper, they define them as having received neoadjuvant therapy prior to surgery, which was chemotherapy first, then chemoradiation, both starting within 24 days. And then TNT was defined as such. So this data, from this data, the overall survival seemed to favor the TNT for all stages. But again, I would say this is retrospective, and also this was a mishmash of treatment modalities. Some of the data is not captured in the NCDB. So these were the findings that for the pathologic complete response, it seemed to be favored by TNT, and it was most likely to have a complete pathologic response as compared to just chemoradiation therapy alone. Survival was a little bit better. But again, the retrospective data, and we go building upon that. This phase 2 clinical trial looking at borderline resectable patients, equals 0 to 1 for FOLFIRINOX with capecitabine chemoradiation therapy, being compared to historical controls that got adjuvant therapy, with the outcome being R0 resection. Again, this showed that the R0 resection was higher in the patients that got TNT. I think it was high as 97% for the patients that underwent resection as compared to the historical controls, which was less than 60%. Just briefly mentioning on local therapies, I don't have much experience with these, but I do understand that, the IRE, which Dr. Ianniti is going to be, publishing that paper. And then there's brachytherapy. Then just briefly mentioning Lab 07 trial, which was looking at the borderline resectable patients with radiation, chemoradiation therapy. And this showed us that, again, overall survival was not improved, but that doesn't necessarily mean that we should not be doing chemoradiation therapy. So in summary, we know that 20 to 50% of patients do not complete, historically, they did not complete the required adjuvant therapy, and that begs the question that neoadjuvant therapy may be the best approach for PDAC. And then 58% of the patients were completing the intended multimodal therapy versus 83% when you compare upfront surgery and neoadjuvant approach. And we have mentioned that NAT really selects for favorable biology and favorable performance status, able to downstage disease, treat micrometastatic disease, because PDAC in itself is a systemic disease. And anatomy has been shown by some of these cases does not predict biology. it's been shown that NAT is associated with improved survival in patients with elevated CA99 in early stage PDAC by some retrospective studies. It is also associated with much better local regional control and overall survival. In that the margin clearance, which is associated with, we have more margin clearance with NAT, and that margin clearance associated with improved survival. I think for me, the prevailing data favors a neoadjuvant approach for locally advanced pancreatic adenocarcinoma.
Thank you, Tashinga. That was an excellent presentation and really well selected cases. So, just sort of to summarize, I think these are very complicated patients, and clearly it needs to be a very individualized approach. All these patients with locally advanced pancreatic cancer ought to be considered for induction / neoadjuvant chemotherapy. And I think a very careful review of their imaging and reconstructive options should be reviewed. There is no good randomized controlled trials that compare chemo to chemoradiation, and I think it's at this point still pretty institution dependent, and sort of the regimen, the radiation regimen they get is also very institution dependent. I think that there have been a lot of good points and arguments about the role of diagnostic laparoscopy in these patients, but remember that biology is king, and giving the patients the test of time with neoadjuvant, as you've correctly alluded to, Tashinga, is really important. And don't forget, just because we can doesn't mean we should, and not every patient with tumor wrapped around the SMA and SMV and maybe one small target vessel is appropriate for surgery, and it really needs to be very individualized to each patient.
It's Brendan again. Can I just second what Rohan is writing? These are extraordinary cases in the hands of an experienced surgeon that are very carefully selected. One is going to CrossFit 5 times a week or something, we heard, had 6 months of chemotherapy up front. And a very experienced surgeon decided to do an uncommon vascular reconstruction. The second one is a lot of arterial involvement. This is more than just a little borderline that you're going to nibble it off the artery after radiation. So obviously at the HPBA, we have some pretty extraordinary surgeons who are pushing this out further and further and doing these extraordinary cases. And when you select patients who are young, fit, have great response to neoadjuvant, taste of time, there's definitely the lunatic fringe that we as a society can continue to push the frontier. But like if this is your oral boards for the HPBA, which is probably coming in a few years, and you see these scans in the first, I don't know how many years of your career, these are unresectable locally advanced pancreas cancers, I believe, unless you have in most centers, these are extraordinarily advanced. These are not routine vascular reconstructions. You're going to take an artery that's abutting for 60 degrees is the first time you nibble on an artery, not one that is, 210 degrees. So I just think these are extraordinary cases, and they show what the frontiers will offer in carefully selected patients potentially. But I don't want people to walk away from this myself thinking that this is the stuff that you're supposed to be doing in close proximity to finishing your fellowship. And I would welcome other, folks to weigh in on that, because I'm obviously trying to make a pretty firm point on this.
%100% agree.
As someone who's
I agree, Brendan.
just
I
sorry,
agree.
as someone
I
who,
think it's a good. Go ahead, Tosh.
sorry, I was just going to say, someone who's just in their first year of practice, this is not something I would attempt.
So yeah, I think there's a paradox here. The patients in which you're going to get the most ginormous operations are likely the ones that get the least biologic mileage. So think about that carefully, right? If the trade-off were opposite, that if you do a ginormous operation that you could offer them 10-year survival, the bigger the case, the bigger the mileage, then for sure go for it. But there's an inverse correlation here, because naturally they have a more advanced disease. So it is extremely important that we have patient selection. I totally agree with Brendan about appropriate patient selection, especially early on in your career. In many ways, we should practice more like plastic surgeons. I mentioned this a lot. When their first year, they really look at the cases they select before they even take their oral boards. I also agree with Dr. Iannides' point earlier about the goals of care. He made a very good point, and that we can argue back and forth about laparoscopy and the appropriateness of it. But the real point is whether you do laparoscopy, PET, or whatever imaging you do, to figure out what is the realistic goals of care and whether you call it, initiation of chemo or whether you truly call it preoperative. And I think that's very important early on for the patient. So I think these are all very good points. I think the whole point of today was to stimulate conversation on still this very controversial topic. So I want to thank Tashinga and Tosh for taking this on. Any other thoughts from the faculty? All right, well, thanks again for coming on today, and we will see you next month. Have a good night.
Bye, everybody. Take care.
Thanks.
Thanks, everyone.
Thank you, everybody.